synthesis of thromboxane, that potent platelet-activating molecule. I want to emphasize a few important points here because aspirin is different than the other non-steroidal anti-inflammatory agents, or NSAIDs, that also inhibit the COX pathway. First of all, aspirin covalently attaches an acetyl group to the COX enzyme, thus inactivating it. To help remind you of acetylation, we've added our aspirin umpire's acetylation whistle. When he blows that whistle, that's it. Really though, you're done. This covalent bond leads to irreversible inhibition of the COX enzyme. Coach Cox isn't just getting scolded, he's getting ejected permanently from the game. Other salicylates and NSAIDs that work on the same pathway do not form this irreversible bond. Once aspirin inactivates COX, it lasts for the lifetime of the platelet, and thromboxane production doesn't resume until new platelets are synthesized, usually in about a week. And the last thing I want to emphasize is that this is both COX-1 and COX-2 that are irreversibly inhibited by aspirin. So in effect, both coaches are getting ejected from the game. This will become more important in our next sketch, where we highlight the specific roles of COX-1 and COX-2 during inflammation. For now, just imagine our aspirin umpire inactivating COX, reducing thromboxane synthesis, and inhibiting platelet activation and aggregation. Okay, so far we've been focusing on regulating platelet function by inhibiting pathways inside the platelet. However, another useful method for inhibiting clot formation involves blocking platelet surface receptors, thus preventing their interaction with factors that promote aggregation. This brings us to the thienopyridines, ticlopidine, clopidogrel, and prasugrel. These agents reduce platelet aggregation by inhibiting the ADP pathway of platelets. Remember all those little leaguers aggregating around first base, ready to make that catch? The sign behind them should remind you that they represent interaction with locally circulating ADP via the surface ADP receptor. Remember, ADP aggregates to platelets. So, ticlopidine, clopidogrel, and prasugrel work by irreversibly blocking the ADP receptor on platelets. Think of it this way. See this hot dog griller in the stands, reflexively leaning in to make the catch with the hot dog bun? Come on, don't look at me like that. It's not his fault, okay? You try holding back your inner Willie Mays after years of undying loyalty to America's pastime. Anyway, whenever we mention the ADP receptor inhibitors, just think of this clopidogrel hot dog grill. Prasugrel and ticagrelor also have the word grill hidden in there somewhere, so it's a fitting symbol for these agents as well. Remember, these drugs cause inhibition of the surface ADP receptor P2Y12, preventing platelet aggregation. This inhibition is irreversible, so once our clopidogrel griller snags that fly ball, he's definitely taking it home with him. All right, aspirin and the P2Y12 ADP inhibitors have established benefit in a variety of cardiovascular disorders, including prevention of coronary artery disease, ischemic stroke, and in the acute management of myocardial infarction. Before we highlight these clinical uses, however, I want you to take one more look at our aspirin umpire. See how red and swollen and puffy he looks? Aspirin is classically associated with allergic symptoms, more strictly defined as pseudoallergy, usually seen in patients with a history of asthma and chronic rhinosinusitis with nasal polyposis. In these patients, urticaria or respiratory symptoms can develop a few hours after administering aspirin. It's also pseudoallergy because it's not IgE mediated. Instead, it involves excessive leukotriene synthesis in the setting of COX inhibition. We'll talk more about this leukotriene unbalance in our asthma management sketch. For now, just remember that in patients who develop allergic symptoms while on aspirin, an ADP inhibitor, such as clopidogrel, can be used as antiplatelet therapy instead, since it doesn't affect the COX pathway. For example, in patients with symptomatic peripheral artery disease, aspirin therapy is often recommended in order to reduce the risk of MI, stroke, and other vascular events. And that's why we've included this excessively greasy and atherosclerotic drain pipe attached to the grill. Aspirin isn't tolerated? Give him clopidogrel instead. Remember, these agents are only for reducing the long-term risk of cardiovascular events. They do not reduce the symptoms of peripheral artery disease, such as atypical pain and claudication in the affected extremity. That agent will be introduced at the end of our sketch. Just be patient, don't get too excited. Okay, Fred Merkel, you know what happened last time. Anyway, where was I? Right, peripheral artery disease. It also puts you at higher risk for developing angina due to coronary artery atherosclerosis. See the grill on the left here? Remind you of anything? I can see you grabbing your chest already as you imagine the pain and pressure of our recurring angina anvil. The optimal management of patients with stable angina requires more than those typical anti-anginal agents such as beta blockers, calcium channel blockers, and nitrates. Therapies aimed at preventing cardiovascular events are central to long-term care. Patients usually begin antiplatelet therapy with aspirin as the first-line agent. Patient allergic to aspirin? Don't worry, switch them over to clopidogrel instead. You know what though? In many clinical scenarios, aspirin and a P2Y12 ADP receptor inhibitor are used together to minimize long-term risk of cardiovascular events. This is called dual antiplatelet therapy and takes advantage of both pathways for reducing platelet aggregation. For example, there is strong evidence to support the early initiation of dual antiplatelet therapy with aspirin and a P2Y12 receptor blocker in patients with acute ST elevation MI. So we've brought back our recurring sketchy symbol for acute MI, the broken heartstrings of a heart-shaped banjo. Platelet adhesion and aggregation are early steps in the formation of occlusive coronary artery thrombus. So antiplatelet therapy should be given as soon as possible to any patient with a STEMI. Also, when administering aspirin, the first tablet should be chewed or crushed to establish a high blood level quickly. That's why if you look again over at our furious aspirin umpire, he's got aspirin tablets flying out of his mouth, chewing on aspirin as he chews out the coaches. Let this remind you of chewing aspirin for immediate effect. Kind of like that immediate need to eject Coach Cox from the game for some acute cheating incident. Wait, cheating? Oh no, say it ain't so, Sosa. It's a corked bat. Huh? Look at it closely though, and it looks almost vascular. I don't know, kind of stenty.